arrows across the way there. So this was 18 years ago. We made some progress. Let's face it, we have made some progress. You'll see it today. There's progress since 2006. Some of the metrics that Hattie showed us, we'll delve into them more today, and where we are, but it's kind of leveled off. We're above the national average on most of this, but below the 90th percentile. And California doesn't, really doesn't, that doesn't satisfy us in the state where we're supposed to be innovators and leaders. So this is kind of a template for some of what you'll hear today. Outside of this, of course, this is just the delivery system. We're going to have a session with Dr. Sky and others, the Blue Zone group, which is a bunch of other things you can do to keep you and I out of the system altogether. But we need more permeability between this system and housing and education and transportation and community social services as well. So with that, I'm going to turn it back over to Hattie, who's going to introduce Dr. Thompson as our initial speaker. Maybe our second speaker. Hattie was the first.
So I'm going to have the chairman of our Sacramento University of Best Practices, our Capital Region, introduce the former chairman of our Capital Region University of Best Practices, Dr. Betsy Thompson, who's here with us from CDC. Thank you for making the trip.
So Steve, you were worried about Hattie stealing your thunder. She just introduced Betsy and said, so we're on. But it is my privilege to introduce Betsy, and Betsy was here in this very position, and Betsy has continued to rise like a meteorite or a star in her career, and now is the director of the program at the CDC, Center for Disease Control. So we're happy to have her back, and happy in her busy schedule that she made time for Sacramento and remembered us. As I said, she is a rear admiral in the Public Health Service at this time, Assistant Surgeon General, and she is the director for the Division for Heart Disease and Stroke Prevention, which happens to be exactly what our focus is today for much of Right Care. And she has has an illustrious career in multiple organizations in the government, but a focus really on one of her issues was to actually look at and work at ways to improve access to and improve the quality of preventive services. And prevention is the way to go. That's going to be one of the themes today as we go. And we're delighted to have Betsy back to tell us where she's been, what she can do, and where we need to go. She was our director. We look forward to her directing at a national level at this time.
Thank you, and it's a real pleasure to be here. And I feel like I could just sit down because Hattie, you said it all, right? What more is there? All joking aside, it is a real pleasure to be here. I've been involved in some way with Right Care, I think, since about 2010. It's been quite a while. But this morning, I want to talk to you about hypertension control in particular, which is not a new topic. It's a little bit like going back to the future, but I think we need to spend a lot more time thinking what else needs to be done in this arena. You know, we live in a world where we're just inundated with a vast amount of information on a daily, if not minute-to-minute basis. It often includes health information, but often it's not necessarily the health information we seek. It's the information that seeks us, that finds its way to us, whether it's through an algorithm, through one of your social media apps, or if you are like me, once in a while find yourself just surfing the internet and going, why am I doing this? Things find you. So that can be, I can figure out which one of these to use. While that can be informative, this word cloud depicts some of the most recently searched and discussed health news topics over the last 7 days, or over a 7-day period, I should say. The larger the font, the more the hits, the more on that particular topic. So it's clear, if you look at this, that media is driven by recent events. If we hadn't limited it to health events, it would have all been blotted out by impeachment. And it particularly covers those that are most sensational, or deeply disturbing, not necessarily having anything to do with the impact in terms of the lives that are taken or other actual measures of health. In fact, some of the major conditions causing death and illness in this country, which are on here, heart disease, stroke, and diabetes, are not prominently featured here. It looks like my animations aren't working. But regardless of what we see or hear through the media, we all know in this room that cardiovascular disease is far too common. Hattie gave us a very personal incidence of that. But I think every one of you just reflect for a few seconds about how many of you have had a friend, a colleague, a family member, a coworker suffer a cardiovascular event just within the last year. I see a number of heads nodding. I won't make you show your hands. But you know that heart disease and stroke truly are all too common. And that commonness is problematic or notable in at least two ways. First, given the fact that most cardiovascular events are preventable, we estimate that about 80% are preventable, we can say that they are indeed too common. Second, possibly and precisely because cardiovascular disease is so common, it can lead some, including the media, as you just saw, and perhaps even some of us in this room, to become complacent at times, to not see it as the health crisis that it actually is, and to accept as fact that cardiovascular events are inevitable, when the real truth is that we can prevent the vast majority of these. See if that one works. No. So the next picture was of younger folks, just driving home a point that's already been mentioned, that we also make some assumptions about who's affected by these events. And yet we know that younger adults are dealing increasingly with more cardiovascular disease and events, even death and other poor outcomes. You may have seen this recent and rather telling graphic or a version of it from our World in Data. The left bar shows the actual causes of death in the United States for 2016, and it does not look like you can read it, but the top big bar is heart disease, which I think is 26% or so up there, and then about midway, or 2/3 of the way down, there's a darker green that's stroke. Together, heart disease and stroke accounted for over 35% of deaths in the United States in 2016. But look at the second column. These are health topics searched on Google during that same year. And to help you with this, they're circled in red on this one, heart disease and stroke. We're less than 99% of all searches. And the results are similar if you look at more conventional news sources. During 2016, the far right, only 8% of health-related articles in the New York Times were about heart disease and stroke. This holds if you look at The Guardian or others. Am I going in and out on this mic? Okay, let's see if the other mic, I move over here, if that stays constant. Sounds better? Together, that might be better yet. Okay, I can stand in the middle. So I'm not trying to say that some of the areas that light up in the middle and the far right here, that cancer, homicide, terrorism are unimportant. They are important. But as we can see here, the issues that garner the most media attention and online attention are not always the issues which cause the most death and disability. There are exceptions, of course, as this fairly recent headline from the Wall Street Journal, and one of my favorite health journalists, shows. This headline echoes what we at CDC and many of you already know. We are, in fact, in the middle of a quiet crisis in our nation. In the midst of this sometimes overwhelming information flow that I've been talking about, there's near silence about the daily impact of heart disease and stroke in our nation and world. And regrettably, it seems like the silence is only broken when a public figure or a celebrity is impacted by cardiovascular disease. While those losses are indeed tragic, many of us know another truth, that cardiovascular disease continues to take the lives of our family, friends, neighbors, and colleagues. It's increasingly common and deadly among younger populations, people in the prime of their lives, mothers, fathers, managers, friends, many of the people who make up our workforce. Contrast that back to what I said we already know, that we can change the trajectory of this crisis, and it becomes clear that more action is needed. And we know the specific, sustained, and often simple steps that we need to take to help our friends, employers, family, and even ourselves live longer and healthier lives. I wanted to just share some data points to frame our discussion. These probably aren't new to any of you, so I apologize if they're repetitive. I think you all are aware that heart disease is the #1 killer in the United States. Over 860,000 Americans die from heart disease and stroke each year. Perhaps surprising to some of you is that in 2016, 1 in 3 of these cardiovascular events occurred in adults 35 to 64 years of age. Not the elderly, not Medicare beneficiaries, 1 in 3. And anyone who has recovered from such an event, assisted a family member, rushed to a hospital, lost someone important to them, knows that such events are much more than data points. They're life-changing events, even for those who fully recover. I want to stay on the last data point on this slide for a moment, that 80% figure that I said before. We estimate that 80% of premature deaths from heart disease and stroke can be prevented, representing hundreds of thousands more birthdays celebrated, graduations attended, promotions earned, contributions made to our organization, our communities, and our country. And even more promising, I think, is the fact that we don't need to rely on new R&D for a new medication or a new medical device, new screening or intervention protocols. We can create this change by focusing on risk factors we know, you all know, how to control, and by committing to make those simple, smart, and sustained steps that I mentioned earlier. Just a few more data points, I promise. Controlling hypertension is my focal point today, as well as the top priority for our Division for Heart Disease and Stroke Prevention at CDC. And that is simply because improving blood pressure control in the United States has the greatest potential impact over the shortest period of time to improve the cardiovascular health of our nation. And in fact, this is true globally as well. And hypertension as well is indeed very common. More than 104 million Americans live with stage 1 or stage 2 hypertension. Of these, about 1 in 3 Americans actually have stage 2 hypertension. That's 78 million individuals with a blood pressure at or above 140/90. And as you know, stage 2 hypertension places individuals at even greater risk for more cardiovascular disease events and poorer outcomes. More broadly, we know that 1 in 6 deaths in 2017 was accompanied by a hypertension diagnosis. But this slide tells the story of hypertension over the course of the last 17 years. The blue line at the bottom shows that the actual rate of hypertension has been largely unchanged throughout the period of 1999 through 2016. But the green line, the hypertension control rate, has not improved since 2007. So less than half, 48.3% of the last NHANES data, of those with stage 2 hypertension have it under control in 2015 and 2017. Now, I know a lot of you are doing much better than that, but don't pat yourselves on the back too much yet, because I'm going to get to you all too. This national number then must change, especially when we know that health systems, clinics, communities, any of them that prioritize hypertension control can reach 80% or even 90% control rates across very diverse settings in a fairly short period of time, as some of you have demonstrated. We have work to do. Heart disease death rates have declined for decades since the 1970s until recently. Since 2010, the national declines have either stagnated and are increasing in many counties and for some populations. These increases are especially prominent among the younger age groups, the 35 to 64-year-olds that I mentioned earlier. Although the highest heart disease death rates occur primarily in the southeast United States, where I now live, increases in death rates among the 35 to 64-year-olds have occurred in over 68% of counties across the entire country. And while California is faring slightly better, at least the 35 to 64-year-olds, the majority of counties, that is over 55% of California counties, experienced an increase in heart disease mortality between 2010 to 2017. The maps on this slide depict heart disease mortality among 35 to 64-year-olds in California. On the left, you have the rate by county at one point in time in 2017. The darker the blue, the higher the death rate. On the right, these are the county level changes in heart disease mortality between 2010 and 2017 for 35 to 64-year-olds. On this map, the darker the red, the greater the increase in mortality. The darker the gray, the greater the decrease. In your data, in your own book that Hattie demonstrated to you, showed as well for this group, that age group, that over about 100,000 of the 298,000 hospitalizations for heart disease and stroke in that data source were among those less than 65 years of age. This is why this group is one of our priority populations. Many of you are familiar with Million Hearts that we co-lead along with the Centers for Medicare and Medicaid Services. It's an initiative, if you're not familiar with it, that aims to prevent 1 million heart attacks, strokes, and other cardiovascular events over a 5-year period. And that this 5-year period will end at the end of 2021. As depicted here, the initiative is focused on a specific set of priorities listed across the bottom that we know will maximize the reduction of those cardiovascular events. And to drive my point home of why we're so focused on hypertension control, as you can see by the height of the bar for blood pressure control, improving this metric alone could prevent over 500,000 of those million events. Yet, hypertension, as mentioned by Hattie, is largely an asymptomatic disease. So many affected individuals, even if they are aware they have hypertension, which her mother was not, but even those who are aware may not see it as critical or requiring action. And yet we know that uncontrolled hypertension is a major contribution not only to heart attack and stroke, but to heart failure, kidney disease, and even dementia. It's also extremely costly, not only in the human terms that we've talked about, but also in fiscal terms, to the tune of over $130 billion annually, just for medication, healthcare services, and missed days of work. This is another slide I have with California specific data from our Million Hearts team and an MWR that they put out last year. The red circle highlights the number of preventable events and hospitalization that among adults during 2017 to 2021 that we would like to see in California. On this slide they circled a different one. That's actually the total number of events that occurred in California, would occur in California during the 5-year period without intervention. The top table, though, are Million Hearts events in 2016 that in California that Million Hearts seeks to prevent. So there are ED visits, hospitalizations, as well as hospitalization costs and the mortality rate. The bottom table shows the number of events expected to occur over the 5-year period without any intervention. The total number circled in red is in thousands, so that's actually 1.5 million mutually exclusive events expected to cost the state at least $22 billion. We had estimated in this MMWR that if every state decreased the number of events by just 6%, we could meet our goal of 1 million events prevented. And that's the number that you see to the right of the one that's circled, not the one that's circled. 93,500 events in California would need to be prevented. That's 93,500 of more than 1.5 million events. You all can do that. I know you can. So what are we doing at CDC to help with this besides million hearts? Some of you have seen this slide before. We have 4 main buckets of work. We do a lot in epidemiology and surveillance with a focus these days on modernizing our surveillance. And when I came to the division, I was sort of shocked to find out that some of our main metrics we weren't getting for 2 years. So when we have a 5-year initiative and we don't get the data for 2 to 2.5 years, we're kind of dead in the water. So we've been doing a lot of work on getting timely, nearly real-time data for some of our metrics. We also do a lot of applied research and evaluation to help determine what works and get it out to all of you in the field. We also fund states, the District of Columbia, territories, and local health departments. Happy to see some of our grantees here, Caroline. And then finally, communications, dissemination, collaboration, because we can't do this work in any way alone. But more must be done, because as I showed you, we are not moving the needle on hypertension control. This past September, we convened a panel, a national summit focused on hypertension. So Right Care was well represented there, to engage key sectors of our society that haven't really been partnering in this area. Employers, payers, clinicians who have been there, national health, non-governmental organizations, thought leaders, philanthropy, as well as government. And the objective was to initiate a multi-sector dialogue, but more importantly, commitment to actions that will help us achieve a national hypertension control rate of 80% or better. This slide is just part of a graphic recording from the summit that highlights some of the ways that the attendees plan to engage. I want to review just a few of the strategies that we know work in a bit more detail. Employers are a big focus of mine and the division currently, because we haven't really engaged with them. They've had a lot of focus, and we've supported some of this around worksite wellness. And while the focus on wellness is understandable, even laudable, that has not resulted in improved cardiovascular health. I haven't seen a study that shows improved cardiovascular health. And yet the workforce and their family members, retirees, are increasingly living with and dying from cardiovascular disease. So what are we asking employers to think about more? Value-based insurance design. We've already talked a little bit about sort of changing the risk model and actually getting value rather than volume for the coverage. Requiring coverage for certain services, including self-measured blood pressure monitoring. So coverage for high-value services, but no coverage for low-value services. Now we know even high-deductible health plans can cover chronic medications, including antihypertensive medications, in front of the deductible. That's a new change, and we want to get that word out to employers, especially, a number of employers that have high deductible health plans. The Community Preventive Services Task Force, through work we funded, also recently found that reducing out-of-pocket costs for medication increased medication adherence and lowered blood pressure, lowered LDL levels, and improved hemoglobin A1C levels. Employers can require that performance standards be met. Pharmacists, we have a number of you in the room and some real leaders in this area. There are a number of studies demonstrating the benefit of including pharmacists, including community-based pharmacies and pharmacists in the care team. Again, I'll refer you to the community guide if this is an area that you're not familiar with, where you can learn more about the benefits of things like collaborative practice agreements and medication therapy management. These have demonstrated cost effectiveness at not just reducing blood pressure, but also LDL cholesterol and improving glycemic control by increasing medication adherence and a variety of other benefits. Healthcare, health plans, clinicians, you all can teach me more about this. I want to hear more in some of the sessions today about what has been working and what hasn't been working. But we really focus our work on three areas: increasing team-based care, and not just those within your walls. Considering community health workers, if you haven't already. We have some folks here that are leaders in the state around that. And patient engagement, true patient engagement. Expanding the use of clinical decision support systems. I already mentioned self-measured blood pressure, but that really is underutilized. And it's right now. I think this is the time for widespread adoption with the expanded coverage we've seen with new CPT codes and an increasing evidence base. Along with that is self-management support and education. Payers, I think it's very similar for folks that consider themselves payers and not so much a health plan, but the preventive benefits, new payment models for medication therapy, coordinated plans for hypertension, and back to that value-based insurance design. So there are a number of others. I think for those of you who are in communities where you're trying to do this work and haven't engaged with all the partners I just mentioned, think about who else you might partner with, particularly those who might bring money to the table and help you. There's a lot of philanthropists and a lot of foundations out there that are able to help and want to be part of the efforts locally. So much remains to be done. We'll be convening a hypertension control roundtable as a follow-up to the summit in order not just to share best practices, but also to make additional commitments and achievements. But as you all know, improving our national blood pressure control rate is not going to occur because of actions that we take at the national or federal level. Multi-sector collaboration and commitments need to be happening in communities across our country, across this state, where those with hypertension live, work, study, and play. So in addition to the roundtable, we have a couple of other things going on. One that I will mention is the Million Hearts Hospital and Health Systems Recognition Program that we will hope to stand up in the near future because we know that high-performing hospitals and health systems can have a huge impact at the community level. This recognition program won't be quite as difficult to achieve as our hypertension control champions because it's really about identifying and recognizing hospitals and health systems who have committed to taking on actions, not necessarily achieving a certain outcome, although we do want to see that as well. So that's just a little sampler of what's to come. But let's stop talking about CDC and get back to you all. I've thanked the Right Care family before for the work that you have all led through both Right Care and your respective organizations. But I really want us to focus today and beyond on what more can be done. I know from some of your most recent data that was shared with me that while some of you have continued to improve and made really substantial improvements in blood pressure control in the last few years, you all know who you are, others have slipped a bit or even stalled. And Kaiser, I'm so sad, I used to brag about y'all. I still will brag about Kaiser. But it was really nice to see Kaiser was at 90%, that even big systems can do this. So my challenge to all of you is to do everything you reasonably can do to achieve the national goal of improving hypertension control to at least 80%. Now, the full disclosure, a national level of 80% means that every one of you in this room has to be above that because we have really 4 low resource areas that will be very, very hard, if not impossible, for them to achieve. And I consider you all exemplar plans and practices So we know what you can do. This isn't rocket science. We know what works. You know what works. Through our Million Hearts Hypertension Champion